ladies and gentlemen, and esteemed members of the Rare Disease Society of Nepal, as a renowned father of medical genetics, Dr. Victor Kausik once said, for every disease there is a gene. Right the same way, in the world and in Nepal, where clinical genetics is gaining momentum, this webinar will surely mark a pivotal role today. It is a great privilege to welcome a renowned professor and head from Department of Medical Genetics at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India, Professor Dr. Kausik Mandal today. Sir holds an MBBS from NRS Medical College, Kolkata in 1999, MD in Pediatrics from Maulana Azad Medical College 2003, and DM in Medical Genetics from SGPGI 2009. He brings over 20 years of expertise in rare pediatric genetic disorders. Sir is in SGPGI since 2013. Renowned for his work on neonatal dysmorphology, Noonan syndrome, lysosomal storage disorders like Hunter and Gaucher's disease, and chromosomal microarray applications, Professor Mandal has authored over 40 peer-reviewed publications. His awards include All India rank 16th in MD entrance and gold medals with research on monogenic disorders in consanguineous families and mucopolysaccharidosis holding special relevance for Nepal. Sir is humble and has interests beyond medicine. He is a musician and an enthusiast biker. And most importantly, he is a kind human who always looks out for everyone. I am lucky to be a student of his. So I request all of you to join me in giving a warm welcome to Professor Kausik Mandal sir for his talk on Introduction to Clinical Genetics today. His talk will be for about half an hour, and then we'll have question answer sessions. Thank you. With this, we begin the talk. I give on the floor to you, sir.
Thank you so much for the kind introduction. So maybe I will share my own experience how after doing pediatrics, I started doing genetics. I started learning genetics, and many of you at different fields where you are working, uh, some in diagnostics, pathology, some in pediatrics, some in obstetrics, some in various other areas of interest when you come to join the medical science. As a child, we have a lot of dreams and visions. So, but sometimes we'll we don't really have those visions in front, and we have to struggle hard for our livelihood. And during that process, you choose to do something, and you start loving that work. So, probably as a child, very few of us thought that we will be doctors or we will be researchers, we will be doing diagnostics or doing something which is beyond our interest. But gradually, while we start doing, we start liking them. So, as told by Dr. Pragya, mm, I never thought that I will be a doctor, I will be a clinician, I will be doing genetics. But as time went on, uh, after class 12th, we have to choose between mathematics or biology. So I thought biology will be a easier bit, and I chose biology. And gradually, during biology, while doing MBBS, we learned that there is no way that we can shun reading and writing. So we have to keep on read and write. And during that process, I found clinical science to be very, very attractive. So while we secure certain ranks, and then we have to choose. So I chose pediatrics. Then I started loving pediatrics. During pediatrics, we started seeing children where there is no diagnosis. So I will tell you how I transformed myself, or probably I introduced myself into clinical genetics, and now I am going on with it. So that many of you who are here, like this is my disclaimer, I have no conflict of interest, no financial relationships. during this lecture. I might be talking about certain medicines and drugs. I have no financial relationships with those as well. So, as I have told you, medical genetics service has lot of branches like diagnostic service where molecular pathologists come into our purview and we work closely with them. We have pediatricians where they choose to do this morphology diagnosis and they refer to us. Then we have good liaisa with those pediatricians who primarily sees those patients. Then we have fetal medicine experts and we do prenatal testing. And sometimes when the patients cannot travel with us, we have other fetal medicine experts in other part of the country where we tell them uh, and we go hand in hand to give prenatal diagnosis. Prenatal diagnosis, as you all know, is doing the test in the womb. So when there is a structural anomaly in the first child, and you can see by ultrasound. Otherwise, we generally do by a molecular testing, by a CVS or amniocentesis. Either we do DNA based test or we do chromosome based test, depending upon what disorder we are looking to. Like for Down syndrome, we'll take out fluid and we look at the chromosomes because you all know that Down syndrome is trisomy 21. But for Duchenne muscular dystrophy, which is a genetic disorder, a single gene disorder where 75% of them are due to deletion duplications, we'll do first in the earlier child, confirm the familial mutation, and then we do take a CVS. Same for SMA, spinal muscular atrophy. You all know about spinal muscular atrophy. There are medications which has come, which has actually more than three medications, and one of the oral drug has flooded the market. There's an Indian company who has manufactured that drug, and it has come down to very minimal. So at a time when we thought that therapy is not a choice for genetic disorders, it is not so now, like for SMA. But still, we do a lot of prenatal testing because even if you start a therapy, if you can't really change the genes, you can have gene modifying agents, but still the outcome becomes poor and it is very difficult for the family to carry on the diagnostic odyssey and the treatment odyssey for the child. So we have prenatal testing, and it is a multidisciplinary team approach, and we have genetic counselors who help us. But most of the genetic counseling is done by geneticists and other clinical experts or lab experts. Like there will be lab experts for cancer genetics. Will we do prenatal counseling and also pre-test and post-test counseling while we test for cancers. So there will be many people who are the branches of a large tree, which is called medical genetics. So these are the medical genetics center in India, and you see that we are very close to Nepal. SGPJ is very close to Nepal, and I am very excited to have collaboration with the people of Nepal. I have gone to Nepal few times and I found that this is a country which is very close to our heart. And we had also patients who are traveling from Nepal to us for genetic disorders. When we apply for charitable access to different companies, it becomes very difficult if they do not have Indian mm, address or something. So I wish that Nepal grows like a sovereign or one-stop treatment facility for people of Nepal. So we are very keen to hold hands and develop services there because we are very close to Nepal, and it is my personal interest because Nepal is a place where there are a lot of trails for motorcycling. So, jokes apart, we'll be talking about these various centers which are there all over our country, and you can see that they are spread all over except for small parts in the Northeast. But recently, Northeast has got two, three centers, and I'm sorry that I did not. This is an older slide, and in the next slide, we'll add up centers in the Northeast and also in Orissa. So we have these centers which have started early with facilities all over the country. And we also have Nepal now with us. So again, these are the clinical geneticists. Even if you have, see, they are all clustered in the north of India, and some of them are in the south as well. But East India is still somewhat lacking, but they are growing very fast. Northeast and East India is growing very fast. We have now clinical geneticists. Again, this is a older slide, and we have lot of arrowheads in the east as well. And as you can see, we have some in Nepal. We have talked that we have clinical geneticists all over the country, and we also now have in Nepal. And I welcome you for our 14 days course, and also for we have observerships. Anybody can come for observership. You just put in an email. We'll make arrangements for your guest houses, and we'll make arrangements. If somebody wants to come for 1 month for a cytogenetics course, for a molecular genetics course, for a genetic counseling course, for a prenatal testing course, whatever you want, we can facilitate those for you so that Nepal grows as a very strong neighbor for us. So why clinical genetic services is required? Because all children born all over the world, 3% of them had at least one major malformation. And believe me, more than 15% all over the world, pediatric admissions are due to genetic disorders only. But we generally overlook, we think that genetic disorders are not treatable. But now you see that after good diagnostic tests, genetic disorders are treatable, and also prenatal testing is available. Then there is some stigma, who to blame, uh, uh, why did it happen. So every person or every family who comes to me will tell that, doctor, we never had anything like this in our family. But you all know that many genetic disorders like autosomal recessive conditions, de novo chromosomal conditions, they don't occur in the family. But once they have occurred, they might X-linked disorders. You may not see at all that somebody has affected, or people have forgot that a child was affected and the child died. Sometimes it is de novo in the parents or in the mother, and but once it has happened, we are always liable to have a prenatal testing, or we should always tell that a prenatal testing in next pregnancy can be done if we detect. So it is very important if we detect the variation or the mutation or the chromosomal anomaly in the first child. So getting to the bottom of it is very, very important, because once you know that this is disorder, you will know that there are certain myopathies which actually improves with time. There are certain disorders which are neurodegenerative. There are certain disorders which, when treated, have a good outcome. So if you know the etiology, and if you go to the bottom of it, you can tell what is the outcome and what is the recurrence risk, whether it is autosomal recessive condition, a dominant condition. How can you prevent recurrence in the family? So as I told you, I will start up with my stories. So this is a time when I was working in Delhi, and these are the two children I have seen. You see that they have large liver. They were the parents gave us consent to mark their liver and show that they have large hepatomegaly. Spleen were not that large, but they have splenomegaly as well. And they looked like muscular hypertrophy. They had protuberant abdomens. They were twins, but both of them were born with some genetic condition. So you can see that they are twins. You see the pedigree, and probably parents are carriers. I should have shaded half of them. Uh, Maybe one day we can take a class on pedigree drawing so that you are very sure. So the diagnosis we never knew, and it was the end of a busy OPD. Nobody was seeing these children. I was doing pediatrics, SRship in pediatrics after my MD, and I was working in the pediatric neurology unit. So they have some intellectual disability. So I thought this is very, very different. And then we looked up Smith's book, and you see that these children also have acanthosis nigricans. You can see the armpit in the nape of the neck. They are different children, and you see that this folded skin and uh, look of muscular hypertrophy. So they have very high insulin levels, increase in insulin levels, because their mm, peripheral tissue, that means the cells are uh, resistant to insulin and they develop diabetes. So they are called lipoatrophic diabetes and they have very high triglycerides. So you can do, so what we did, we thought that this must be this disorder and we did just a triglyceride and insulin level and we proved that they have a disorder called congenital lipodystrophy or biradenalism or just congenital lipodystrophy. So this is the person who have first described them and we did a mutation testing at that time. It was probably 2004, 4 or 5, and we did not have this amount of Sanger sequencing facilities or any other sequencing facilities. And this is a single gene disorder, we know. So we had to send this to a researcher who was doing this work uh, and has been seeing congenital lipodystrophy in Belgium. So we sent DNA, and this was the mutation. So IVS is intervening sequence. That means this is intron, and minus 11 means it is 11 nucleotides proximal to the first nucleotide of next exon, right? So I will show you the picture. So later on, what we did now we don't put this type of nomenclature. We put with a C dot number. But just to tell you, just to introduce you. So now what we do Sanger sequencing. Previously also we did, but they did Sanger sequencing. And later on when I joined SGPGI, we had a Sanger sequencer. We did it. And you see that we amplify exons and exon intron boundaries in Sanger sequencing, exon by exon. So this gene has probably got 11 exons or 14 exons, and they did the sequencing of all the exons and they gave us the exact area of mutation. Then we actually designed primers, and this was exon 3. This was 11 nucleotides proximal to the first nucleotide. So see, a normal there should be an A. In a patient, it has been changed into G, right? uh, G, and in parents they are heterozygous, right? And in parents they are heterozygous. There are actually two A's here. There are two A's, so it's the broad peak, so they are normal, right? So, and in a patient there is one A and another A is changed to G, so homozygous. And in parents, you see that both A and G peak are in the same place, so they are carriers. So later on we did, and we have proven with Sanger sequencing in-house that this is this mutation. But we thought that Sanger sequencing had been very, very difficult, and there may be many more people in the same community with the same disorder. So here I have shown you that this is intervening sequence. This is actually exon. This is exon 2. This is intron 2. So introns are called intervening sequences because during protein synthesis, introns are spliced off and all exons come together. And we start giving a C dot number from the first nucleotide of exon 1, 2, 3, 4 like this, and now we provide a C dot number for, we should have been providing a C dot number for this, but I use these old nomenclatures just to tell that how I got introduced. So I did not understand what is this. So I got introduced to genetics, and luckily I got through the entrance examination. I went to SGPGI and started learning genetics. So you see that nucleotides will look like this, and this is the exon 3, right? These green are the primers which we have designed. So the primers are actually designed in the intron so that we take some part of the intron and also the whole of exon during Sanger sequencing. So what I thought that let us have an alternative method of diagnosis, because we will be screening the whole mm, family or the whole large whole family. They were from a place in Bihar, and we thought that this is a very uncommon rare mutation and there may be more people with the same mutation, and we can screen a large population. And screening a large population, nowadays it is okay to do Sanger because it is being very cheap to do Sanger now. But at that time we thought, let us do something which is a one shot and we can screen large population where the cost is very less. So this is called PCR RFLP. Mm. When we started doing many other genetic diagnosis, at that time we had PCR RFLP or ARMS PCR, like for thalassemia. ARMS PCR is cheaper and you can do in large population, large number of samples. ARMS PCR doing Sanger sequencing, sample by sample becomes slightly more labor intensive. Nowadays, it has become easy because we got chemicals and sequencer and other machines for Sanger sequencing. But at that time, it was difficult. So anyway, so I thought that let us design a alternative method. So this is an alternative method, and there is a restriction enzyme called. So restriction enzymes are enzymes of bacterial origin, which will cut the DNA. They were actually made to uh, make the bacteria survive against bacteriophages, because bacteriophage, you know that they give DNAs, and the bacteria, when they have this restriction enzyme, they will cut the DNA of the bacteriophage, and to protect them, they develop these enzymes. So this is, and then we have extrapolated this work into our work where we want to have restriction fragment length polymorphism. So this enzyme cuts this 273 base pair band. So once you amplify this will be 273 base pair. And once this enzyme is put, it will cut it into two. And once you see in the gel, you can see that these are homozygous. These two children are homozygous. This 273 band is cut into two, and you can see these two bands, right? They are heterozygous parents where you see this and also these two bands. And this is a normal where only the upper band is there and these two bands are not there, as you see here. So we developed this PCR RFLP, and we told them that please, if you become pregnant, right, please come to us. We have alternative method to check you, because Sanger sequencing then was a new method, and we thought that maybe it won't be very great. And we also told them that please bring all your relatives we can screen for, because as both of the parents are carriers, there is hidden consanguinity and endogamy. So we told, bring your whole clan of people. We'll do this and we'll prevent birth of these children, because the outcome is very poor, as we have thought that there is diabetes. But after many years, maybe few years back, the children grew up. They came to me to meet when I went to Delhi, and they were doing well. Both of them has diabetes. One of them had a bad lung infection as well. One of them had a bad liver problem as well, but they are surviving, and they never got pregnant. They never brought their whole clan to us for this investigation. So I was disheartened, and I thought that doing this exercise would have been bad, but I learned something. So after many, many years, in 2016, I saw this child who is a 12 years old female, poorly built and extremely thin body habitus. You can see joint dislocations. You can see arachnodactyly. So once we see this type of arachnodactyly, we think of Marfan syndrome. So this is a lecture. So can we interact? Can other people speak out so
Yes,
that?
sir. They are free to.
Okay. So anybody wants a differential diagnosis for this? So when we see arachnodactyly, so that means long, slender fingers, you think of Marfan syndrome. And there are other disorders which look like Marfan syndrome. So you see that they have these long, slender fingers. This is called a thumb sign. This is called a wrist sign. But there is joint dislocation. And this facial feature is not like Marfan. These are craniosynostosis syndrome, where they have features like this. But they are differential diagnosis of Marfan. And Marfan, the height is more than the 95th centile. Here you see the height is normal, and head circumference is not is okay types. Weight is also less. So we did echo and X-rays and ophthalmic examinations, because in Marfan, you know, there can be lens subluxation, there can be echo findings of large aorta. So it was not there. There was only mild mitral valve prolapse, and X-rays have shown elbow dislocation, right? So these are all dislocations. You see elbow dislocation in this X-ray. You can see this craniosynostosis syndrome with protrusion of the eyes. So this is disorder called Spindle-Goldberg syndrome, which is a differential diagnosis of Marfan, but the gene is very different. And what this gene is called Sky. So we did Sanger sequencing of the gene. We designed primers and we did Sanger sequencing. This is an autosomal dominant disorder. So you will only get one mutation, right? So in this gene, you should get only one mutation. See, this is one amino acid change into another, and you see two peaks. So this is one mutation. So proband means the child. And we got another variant. Both of them are missense variants, like one amino acid change. So we are not sure. Both were novel. We are not sure which one can be the disease. And we checked in the parents, right? Both father and both mother, neither of them had this variation. We checked paternity and we saw that this is the father and this is the mother. There is no doubt about it. But there were two de novo variants in the person. So we are confused what can be. There cannot be two de novo variants because this is autosomal dominant disorder. And if they are in two different alleles, one from the father, one from the mother, uh, both de novo, then probably we are hitting into something else. What now? What can we do? So we sent for publication, and they told that no, it is not possible to publish this because you have to tell us whether they are in cis or in trans. That means whether they are both in the same allele or in the different allele. Then what we started doing, we had started looking at the stability of the protein and did some software analysis for protein stability. And one of them is mm, less stable and one of them is highly unstable, but that really did not prove something for us. Later on, we found that one of them is found in the population database. But then for cis trans testing, whether they are in the same allele or a different allele, we have to do either cloning or the other method is RFLP. That means when the variant is there, we can cut it and see that in the cut portion whether the other variant is also there or not, right? So they were not very far. These two variants are not very far, and we actually amplified the whole thing, right? This is whole thing along with the variants, right? So once we amplify this, there will be these are the two variants you can see in the same gene, and we amplified the whole thing. And what we did now is that wherein we cut it when the variant is there, it is cut into two, right? So what we did, we actually did a variant. You see that this is digested product, and this is undigested, and this is digested product. And you see that it is cut into two. Then what we did, we actually sequenced one of the upper product to see that the variant is there. So once you have seen that the variant is there, you you are very sure that they are actually in the same allele. That the allele which is cut, the variant is there. That means they are in the same allele. So knowledge is never wasted. We use whatever tools we have. I have learned during that period of my pre-genetic era, my work where we have done pre-genetic. So uh, we what we learned at that time, we actually applied at this place technique called PCR-RFLP to prove whatever we have seen. Right. So this is another disorder. Uh, you see that with coarse faces, you see the eyebrows like this. So it is not that the child is not well kept, but the teeth like this, but it is because of a disorder. And these are the various disorders in the same pathway, like Noonan, cardiofasciocutaneous Costello. So this child had Costello syndrome. And at that time, I was working in CMC Vellore. So they came to us and we told them, yes, probably this is Costello syndrome. And it was an exciting diagnosis at that point of time. This type of skin lesions is very characteristic of this disorder. They have increased creases in the fingers and toes, and it was a very exciting diagnosis for us. We are having a common clinic with developmental pediatrics, genetics and developmental pediatrics, and you see that it is 2009, December 2009, and all people came to see this child. So, and we started discussing whatever happens in the heart in these children. They have intellectual disability, this and that. So, when we started seeing this child, the parents, one of the parents uh, started crying because for them, this child is their hope. This child is their very beautiful child. And we are discussing about the various skin lesions and dysmorphology in these children, in his child. And other people are excited to see and discuss what are the outcomes, what are the complications in front of the parents, right? So this is not done. So we have to be sensitive. Even if we see a child with dysmorphology, because whenever we do clinical genetics, there will be children with dysmorphology, like the first child or the first twins I have shown you. Then the child with craniosynostosis, arachnodactyly, spingal Golgi syndrome, and also this child, you see that they look very, very different from the general population, and they have features which are absolutely not good to look at. But for the parents, their child is very beautiful, their child is very lovable, and we have to be very, very sensitive in front of the parents, and we should never show excitement. So these are the two essential mm, uh, message which I wanted to give you, that whenever you see something, uh, whenever you work on something, it will come up and it will help you do in a future. So knowledge is never wasted. And while seeing these children with rare disease, we have to be very, very sensitive that we should not show our excitement in front of the parents. We have to really discuss in a scientific way. And even while teaching, because while teaching our students, we have to be very sensitive both with the student and also with the parents of the child, that they have to show respect to the parent, to the child, and to show their love to the child, and then discuss whatever be the outcome, give them a summary and tell that this will be the outcome, this is how we can prevent complications in your child, this is how we can prevent birth of another child in your family, these are the treatment facilities, these are the prenatal testing facilities. So these are the very two important messages which I wanted to give you. And during my practice, maybe the third scenario, this is a child with developmental delay. There is no family history. There was imperforate anus, which was operated, and you can see the thumbs and great toes, they are short. So this child also had some prominent forehead, some dysmorphism, and the brain shows agenesis of corpus callosum. You can see this agenesis, and this is probably partially holoprosencephaly in this child. So there are use of books and databases. So once you see a child, you can use Smith recognizable pattern of human malformation, is a book where there is enlisted. You can just type in OMIM and see features in OMIM, online Mendelian Inheritance of Man. There were certain databases like London Medical Databases, POSUM, where we previously used to use. Then there are phenomizers that you, where you derived your HPO terms. So these are various ways where you can check and see what disorder the child might have. Then you start looking at the genes at the etiology so that you can do correct diagnostic methods. So sending NGS is not at all without a known or without a provisional diagnosis is not fruitful, and that will give you very little results, right? So what we did, we went through, this is OMIM database. You know all about Mendel. I won't go in details. And this is London Medical Database or Dysmorphology Database. So I put these features in London Medical Databases, and we thought that these. So you can go through. This is just So for this child, we have hypoplastic thumb, metapygrism, perforated anal, holoprosencephaly, developmental delay. And I hit into a diagnosis called Barrett-Jarosz syndrome, which is a single gene disorder. But at that time, we did not have NGS, and we had a protocol that for all children with developmental delay, we do a karyotype first. So we did routine karyotyping, and you see that this is a normal 13, and this is another 13 where this distal portion of 13 is missing, right? So this is called 13q deletion syndrome, where the features are absolutely similar to what we have described: hypoplastic thumb, metopic ridge, some brain anomalies. And once you see the genes, you see that there is a gene called GIC2, which is responsible for holoprosencephaly. There is also a gene called GPC5, distal to the deletion, which is expressed in the mesenchymal limb bud, and they have limb difficulties. This is another gene which was proximal to the deletion which we have. This is called retinoblastoma gene. But for this family, what we told is that, see, RB1 gene is not deleted, so we do not need retinoblastoma surveillance at least for this child. Otherwise, we have to do a retinoblastoma surveillance, and because retinoblastoma is a gene which will affect uh, formation of retinoblastoma in the eye, which will cause retinoblastoma in the eye. You need Knudsen two hit hypothesis, and we have to put the child on surveillance. But for this child, because this gene was not deleted, it was proximal, so we could explain them that because of deletion of these two genes, the features are there in the child, and the child does not require retinoblastoma surveillance. So what I learned is that systemic evaluation is more important than a smart diagnosis. I did a smart diagnosis using a London medical database, but because we are systematic, had we not found the chromosomal anomaly, we could have done the genetic diagnosis, except for disorders like Duchenne muscular dystrophy, which is very classical, SMA, which is very classical, we don't do. But for all children with intellectual disability, where we really do not have a good handle to tell that this is this disorder, this is a single gene disorder, uh, we should go through a systemic evaluation, right? Then we see case scenarios. Uh, you all know Down syndrome, and this is a series of books, series of journal articles which you can go through AJMG. You will get it. You can download them and see what is cryptophthalmos, what is blepharophimosis. These are the terms which we use during our dysmorphology diagnosis. You see ptosis. These are family and children with Noonan syndrome. Then you can have cryptophthalmos. That means one eye is not there. So this is Fraser syndrome. This is called epicanthus superciliaris. I am not going into details because there is no point describing this. You can go through. So this is proptosis. You see that there are bulging eyes, as we have seen in Spindle-Goldberg syndrome. But this is a very classical disorder where you have this pseudosyndactyly or syndactyly, and digital anomalies along with craniosynostosis. Remember that in craniosynostosis, that does not mean you don't have the sutures. You have the sutures. They are very prominent in one side, and the other part it will be open because the brain needs to grow. And they are children with craniosynostosis. This is Eppert syndrome, and there is only one or two mutations which in the same exon which will give rise to Eppert syndrome. And this is again a Sanger sequence where you see. So these are deep set eyes. You see the eyes are very deep set. This is cocaine syndrome. This is a DNA repair defect. They have skin anomalies as well. And they are autosomal recessive conditions. You can see cocaine. They look very cachexic. And these are the two important genes. And both the disorders are autosomal recessive. Then you can see this is called synorphis, where the eyebrows come together. You can see synorphis, and they have a very typical facial gestalt and hand anomalies or limb anomalies. Then they have increased here. So this is called Cornelia-de syndrome. Then when the iris are like this is called heterochromia iris with forelock, white forelock. You see white forelock. So this is called Waardenburg syndrome. This is a disorder. This is autosomal dominant disorder. And we see families with, and 50% of them have deafness. So this is Waardenburg syndrome. This is a syndrome where gene is not very well known. Those are so they have ear anomalies, and this is called the epibulbar dermoid, right? This is very classical. This is second branchial arch. Those who have learned development will know that second branchial arch syndrome, or this is also they also have anomaly in the spine. You see that the spine is defective over here. So this is called golden hair syndrome. A very similar disorder like golden hair, where you see this ear anomaly and one-sided facial anomalies, and you see this is coloboma of iris, right? Coloboma of iris. So that also had some eye anomaly, that is golden hair, and the gene is not well described. Some developmental for this, the gene is very well described, and this is called Chart syndrome. This is an acronym of coloboma of iris. Many of them have heart defects and renal defects. So, and the gene is very well known. Again, you see ears, similar ears, but this is not Charge syndrome because they do not have any eye anomalies and they have intellectual disabilities. Charge might or might not have intellectual disability, but this disorder is a chromosomal disorder where there is an extra chromosome. This is an marker chromosome which has come after when we do in the parents. You see that there is 1122 translocation, and this extra 22 has come in the child, and this is called Emmanuel syndrome. So some of the disorders will look very similar, but then we have to go systematic, and you can find out what is the disorder if you don't know. This is called Rubinstein-Tebby syndrome. They have this overhanging columella. They have very classical facial gesture and hand anomalies and feet anomalies. This type of broad thumbs, broad adducted thumbs. This is a very classical disorder, and this is a single gene disorder. Again, we generally won't do chromosomal analysis first in them. This is because this is a single gene disorder, but a small percentage might also have chromosomal anomalies. And you see that this is the same thing in the fetus, Rubinstein-Tebby syndrome. This is a large pear-shaped nose, very large nose, and you see children have this large nose along with cleft palate, some slender fingers. This is called velocardiofacial syndrome. Velus means palate. Velocardiofacial syndrome. They also have hypocalcemia, and you can check for hypocalcemia. This is a this is a microdeletion syndrome with a very classical age. So this is 22q deletion. You can do fish or you can do microarray. And what we do is MLPA because this is very classical. They have heart defects and uh, other defects. This is, you see this child has cleft lip. This is called a Greek warrior helmet pattern of nose. You see how a Greek warrior helmet looks like. So they have a very, very broad forehead. They are different children. They are three different children, but have similar face. So this is 4p deletion syndrome. Many of them may not be looked into karyotype, and we require either microarray or MLP to look at Wolf-Larsen syndrome. They have severe developmental delay and some dystonic posturing. So this is Wolf-Larsen syndrome. Then these are other uh, disorders with micrognathia or retrognathia. That is, means you have a very small chin, and these are the genes for Nager acrofacial dysostosis. This is full chicks, and when you see this type of chicks, the child eats too much. The child eats too much, but still cries. And in the morning, he is either very cranky, and sometimes they will come up with the history of throwing a seizure. So this is hepatic glycogen storage disease where they get hypoglycemia in the morning. And if you can treat them, there are various varieties hepatic glycogen storage disorders. Various genes are known, and they have been classified as type 1, type 3 glycogen storage disorders. And they need is uncooked corn flour, right? So uncooked corn flour remains with a very specific dose in different times of the day and night. So once you can give them uncooked cornstarch, their sugar level maintains and they thrive well. Their malabsorption disorders are also improved. So this is why I put this picture. So they're a full chick. So they look so chubby, but they really remain malnourished. This is another disorder which looks like glycogen storage disorder, but mm, they have very large liver and spleen. But this is not a glycogen storage disorder, but a defect in the transporter, also called blood transporter. So these are few children, few families with same. Then there is polydactyly. Polydactyly means increase in number of fingers. You see that this is syndactyly and polydactyly. So post-axial, this is pre-axial polydactyly. Pre-axial means beyond the thumb or the great toe, you have polydactyly. So this is pre-axial polydactyly. This is syndactyly. That means they are fused. This is very classical. So this is again a post-axial polydactyly. So this is pre-axial because axis of the body. This is post-axial. Beyond the little toe, if you have a polydactyly, this is called post-axial polydactyly. And this is called insertional polydactyly, right? Insertional polydactyly is very, very classical of a disorder called Pallister-Hall syndrome. They are all single gene disorders due to gene is called GLI3. And there can be certain other genes of the ciliopathy group where they have similar features. But remember that there are disorders which might look very similar. So you see that there is amputation syndactyly and there is constriction rings. So this is a disorder which is absolutely not a genetic disorder, but this is due to amniotic band in the child when the baby was in the womb. The amniotic band has got so streaks of amnion can get dislodged and the limbs can get entangled in these bands and they have this type of disorder. So according to the phenotype, you can find out whether this is a genetic disorder or not. You see, this is very, very asymmetrical. This type of constriction bands and limb anomalies very, very asymmetrical. So this is amniotic band disruption sequence and they do not have any problems. Here you see, here nose, this is hypoplastic alienazi. So this is hypoplastic. They have loss of hairs and they have digital anomalies. This is called trichorhinopharyngeal syndrome. Sometimes they might also have bony defects and intellectual disability because these genes EXT1 and the for this exostosis, so these are bony defects. So this is called Langer-Giddens syndrome or EXT trichorhinopharyngeal type 2. See, one is a single gene disorder due to mutation in a gene, and this is a contiguous gene deletion syndrome where more than one gene is deleted. This is a disorder where you can start thinking that they have webbing of neck and this type of pedal edema. You start thinking of Noonan syndrome, but this is not Noonan syndrome. The child was not short. The secondary sexual characters are good. And the father also had this. So this is autosomal dominant condition called lymphedema distichiasis. This is a primary lymphedema syndrome. And once you know that this is a genetic disorder, you can counsel them that the outcome is good. What you only require is to remove the extra row of eyelashes, which is irritating the cornea, and probably some cosmetic correction if required. This is osteogenesis imperfecta. There are many genes and large genes. You know that there can be bony defects, there can be breaks, and bisphosphonates are available to decrease the fractures. This is another disorder with fractures with teeth anomalies, and this is very classical spatulate fingers. And once you do the X-rays, see the same children with this, so they have increased bone fragility, but the outcome is good. And once you see the X-rays, it looks like osteopetrosis. They're very dense bones, but they are fragile bones. You see, this is how osteopetrosis look like Ragard spine, and the cortex is thick and the bone are very dense and they have Warmian bones. So this is called pycnodysostoses. So this is called pycnodysostoses and the outcome is very good. So sometimes we see babies which do not survive. This is a family and you see that the baby did not survive and they are oligohydramnios. So this is occipital encephalocele. We don't see kidneys like this when we open up the fetus. So we also do fetal autopsy. So if there may be pathologists in this group, and you can see fetal autopsy gives us lots and lots of information. So the kidneys with multiple cysts, which looks like almost bunch of grapes, and these are very large kidneys with occipital encephalocele. Again, this is a ciliopathy, which is called Meckel-Gruber syndrome, and more than one gene is known. And you see that there is a group of babies which we have seen with Meckel-Gruber syndrome. We have published in this series. So Meckel-Gruber syndrome is a ciliopathy. Then there are some behavioral and mannerism defects, like this is MPS 3 or hyperactivity, many of these children are diagnosed as uh, autism or ADHD. Then this is midline hand movement, very classical of a disorder of X-linked dominant disorder called Rett syndrome. This is very happy or happy puppet syndrome, also called Angelman syndrome. Obese children, they are all microdeletion syndrome. Again, this is Williams syndrome. These two children have Williams syndrome. They are very friendly, and you can make out from their gestalt, from their face, from their behavior that they have these common microdeletion syndromes. For we, what we do is just an MLP, right? So these are children which I have seen at different phases with Williams syndrome, and this is what it is. It is deletion with Williams syndrome. Then there are disorders where we do, you cannot do karyotype, you cannot do MLP, you cannot do microarray, you cannot do Sanger sequencing, you cannot do NGS to find them. These are epigenetic disorders, large tongue, and what is done is a methylation test or methylation MLPA, because these children have hypoglycemia in the neonatal period. This is called Beckwith-Badman syndrome, where these children have hypoglycemia during the neonatal period. And see these hypoglycemias, once you see this hypoglycemia, you can, if you prevent hyperglycemia, their outcome is good. They are also prone to develop embryonal tumors. So diagnosis is very important, and probably the only diagnosis is a very large tongue and sometimes umbilical hernia or omphalocele. And this is methylation disorder. And what we need to do is methylation test, methylation MLPA. So suspecting a disorder is very important, and it helps in deciding what test is to be done. The eyes do not see what the mind do not know. So this is an example. So you can see there is stridor. The nose is, you can see the small nose, depressed by the, and the other is sounds are, this is a sound of a neonatal nursery. So you see this nose stridor because of the small nose. And if you look intently, there are punctate lesions. You can see in the uh, ankle and also sometimes in the pelvis, there are punctate lesions. So this is a disorder which is called fetal warfarin syndrome. So the mother had heart disease and the mother was on warfarin. So we have to remember there are disorders which are preventable, because during pregnancy, if you have put her away from warfarin and given heparin during a certain period of organogenesis, probably this could have been prevented. So not all dysmorphism you see are genetic disorders, as I have told you about amniotic band disruption. And also for various teratogenic disorders, they are not all dysmorphic syndrome are genetic in origin, and there is lot of ways to prevent this, right? So nowadays, when they are mother with prosthetic halbwraps or warfarin, we tell them during pregnancy that what is to be done. So a thorough examination is of utmost importance, whether it is neonatal, fetal. Then we have antenatal diagnosis, but for that, a proper diagnosis etiology is a must, and we can use help of databases, and we can take help of colleagues for a diagnosis. Knowledge is never wasted. You can see that where what we have learned very early in life, we can use it later on. Systemic evaluation is better than a smart diagnosis. And the what the mind does not, so the eyes cannot see. We have to be very sensitive while we see children with dysmorphism. There are certain gestalt diagnoses. I have told you about Williams syndrome. And management of these patients is a reality, but it is a teamwork. We have to have physiotherapists, occupational therapists, genetic counselor, the diagnostic labs, which should do a diagnosis, but there should be a pre-test and a post-test counseling before doing a test and after a test is done. So, like riding a motorcycle, the principles of riding is that you have to have awareness of the surrounding. Then you should know how when to accelerate and when to smooth brake during genetic counseling. Then how to do a counter steering at trans. Then we need practice, right? So a clinical geneticist should keep on practicing. We should have sessions where we can meet and we can have practice. Then we follow certain rules. Then obviously group riding is safe and thrilling. So likely if we do it together in clinical genetics, we'll keep on doing more and we'll learn more, and definitely it will be safer because there will be a lot of litigations as well, uh, even for prenatal testing, when fetal medicine experts orders a test, then a test comes wrong, a prenatal testing comes wrong. So definitely, if it is a group, if you work in a group, then we all are safe because you know that this is there will be human errors, right? Because of lack of knowledge, because of lack of communication, there will be human errors. The human errors will be there, and we can face a lot of litigation. A lot of drug companies go against you, will bribe you, will try to influence your action, will threaten you with their consequences. But if it is a group and we know what is wrong and what is right, we'll be safe, right? So, what test is to be done? See, large tongue, anybody? And what test we should do in this child? Anybody can tell? So, this is not Beckwith-Whitman syndrome. This is congenital hypothyroidism, and what you need to do is just to do a TSH and T3, T4 to know. And this is a grown-up child with this disorder later on. So this causes intellectual disability, and this is one of the commonest preventable cause of intellectual disability, which we can prevent. So newborn screening is important for congenital hypothyroidism, and this is important. So we should never miss a treatable diagnosis. So thanks to the organizers, Dr. Pragya, to my old team, which is Dr. Priyanka, who developed all molecular genetics. So our new team, this is Shashank, who works with me for Sanger sequencing. This is Dr. Deepti, who does prenatal testing and who takes up our all prenatal testing things. This is Brijesh, who does MLPA for us. This is our Pragya, who was very enthusiastic in this ICMR course. I couldn't see Pooja here. This is Anshika and my family and my extended family who rides motorcycle with me. So thank you so much. So
Uh,
questions.
Thank you so much, sir. The floor is open for questions. Please.
Can I go first?
Yes, Saroj. Yes, please.
Okay, thank you, ma'am. And thank you, Mandal sir. It was really a great webinar, a great presentation. You recaptured it just in one session, the whole genetics I had been studying in my medical school, and I actually recalled it. It's because maybe you showed a lot of diagrams. So it was initially very tough for me during my medical school time. Thank you so much for this. Currently, I'm working at a house officer here in Kathmandu, and I was just curious how should we approach the cases when we suspect some kind of genetic disease, when we see or when we see some patient who have the course dysmorphic feature. However, we couldn't reach up to the diagnosis immediately due to this limited testing in our region. And so, how have you been approaching the cases, and how how have you been counseling the parents, particularly at that time? They really seem anxious, and sometimes we as house officer ourselves get blank at those moments. Thank you.
So do you work in pediatrics?
Oh no, I'm working in the internal medicine department. However, we sometimes rotate to pediatrics as well. They change our shifts, so during the
Okay.
time we
So
sometimes find such cases.
so adults, mostly adults, right?
Oh yes,
So
yes.
in adults, so let me tell you what will be the common group of disorders which you see in adults, genetic disorders. One is ataxias, right? Ataxias, chorias, neurological cases. Most of the neurological cases will be genetics in adults. Then you might be seeing hemophilias where they have bleeding. So first you have always have to have a provisional diagnosis. So you go through, and sometimes, as you have told, that you see children with dysmorphic. So like Down syndrome, I am sure you will be able to recognize it correctly, right? So my suggestion would be you go and you must be having your pediatric colleagues with you working with you. Don't you have
Yes,
pediatric?
we do
Okay.
have.
So the first thing is ki rope in with your pediatrics colleague for a pediatric patient. Rope in with is your neurological colleague for a neurological patient. So first, I think you should rope in with your pediatric colleague. So pediatric colleague, because they must be seeing Down syndrome, Duchenne muscular dystrophy, SMA, right? So these things will be the commonest of them, and many of them has good diagnostic facilities. So first, always have to have a provisional diagnosis. Then definitely Nepal must be having, or there will be private labs which can collect samples, or you can contact us with pictures and clinical details and your diagnosis. Then we can provide to how you can send samples to. See, private labs are easy, and there will be labs in Nepal. So you have to rope in with all your colleagues where they can do a diagnosis. For Down syndrome, you just need a karyotype. For Duchenne muscular dystrophy, you need a MLP. SMA also you need a MLP. So probably that is the most useful solution, that you rope in with your colleagues who are seeing these patients, then what test from where they are doing, and this will be easy.
Okay, thank you so much, sir. I got my answer. Thank you.
Any questions, please?
Uh, can I ask, ma'am?
Yes, sir. Yes, sir. Please.
Thank you, Professor Kausik, sir. I also got the opportunity to be a student in 2017, that short course of medical genetics, ICMR genetic training course. So after that, we were oriented about genetic diagnosis. So again, I want to thank you for both this lecture and for that training session. So it's not my question, it's my request to sir, because many of us in Nepal are not oriented in genetics, because many of the doctors, clinicians, they think their genetic diseases are still rare. But as we know, it's not so rare because we don't know, so we think it is rare. So my request is, in any other future class, can we have a session about genetic testing? For example, when to send karyotyping, when to send whole exome, clinical exome, MLP, are different testing. So based on disease, so it will be useful to use in clinic for the clinicians, for not who are not geneticists, for example, physicians or pediatricians or obstetrician specialists. So they can use the proper test in, so that our patients can benefit. So it's my request, sir.
Yes, absolutely. That can be done. We can go system wise. We can go diagnostic testing, like we group disorders which are karyotypic and multi. We tell how to find them, that these are the disorders where you can do a karyotype. What can be the glitches where will you miss? So we can take classes on clinical cytogenetics. We can take classes on molecular cytogenetics. We can take classes on single gene disorders. We can take classes on pedigree, so that we start. And that can absolutely be done. Like we do in that ICMR course, which in these 14 days, we can gradually do it on as webinars. That can be done, Dr. Pragya.
Thank you, sir.
Yes, thank you, sir.
Any questions? So I think we are at the end of the session. Uh, I think we should end by now, since there are no questions. Uh, I
Yes,
would
yes,
like to
please.
inform you that it is a recorded webinar, and since a chilly morning here with rounds and everything, the students and the clinicians can still hear it recorded in our website. And then I think for these students and all, the most important part for me was the phenotypic applications like phase 2 gene and OMIM, what you discussed, sir. Thank you so much, sir, for gracing us with your expertise this morning, taking your valuable time. And I'm sure your insights will illuminate the path for clinical genetics for all of us who are the beginners here. We are deeply grateful for you, sir, for being with us this morning. I wholeheartedly thank you from the audience, from the RDSN family, and me as a student myself. Thank you very much, sir.
Thank you. It was my pleasure to be here. And I wish that with our, what shall I tell, with a discussion with us, and some of you come for training, not only for that 14 days course, but please come for a month for training in different, like I have sent you the primers for
Yes, sir.
multiplex PCR. So if you come, you can see MLPA, or some of your students can come and see the techniques and gradually develop diagnostic tests in-house in Nepal, in government or private, I don't know. But you are all welcome to learn how to develop a lab, because you, and also how to develop clinics, because once you have clinics, the probably the most suffocating part for all clinicians is that they can see this disorder but they have no way to make a diagnosis. There will be certain disorders where diagnosis, for getting a diagnostic test like physioscapulohumeral dystrophy, right? We see it is not done by NGs, it's not done by any method. So it can be done only by optical genome mapping, and we don't have. The test is very costly, and after even doing the test, probably nothing could be done for certain disorders, I'm telling. But for most common genetic disorders, though we call it rare, they are not rare, and people are suffering, patients are suffering. So I think developing diagnostic tests which are very easy should be done. And I welcome you. What shall I tell? I want to again emphasize on the fact that please develop diagnostic tests, and I will be there, or we will be there to help you out so that you can develop those tests. So there should not be one center or two center or some centers for diagnosis. There should be many centers for diagnosis, so that patients don't move from place to place. Looks very difficult, or very sad that patients who are suffering are moving from place to place for diagnosis only what they have.
Thank you
So
so much,
thank you.
sir, for this encouragement and motivation. And I know if we just seek, it will be done. Thank you so much, sir, for us all in Nepal and abroad. Thank you so much, sir. I would like to, RDSN family, we will be again in touch with you for future endeavors, sir. Thank you so much. With this, we will
Bye.
end the webinar today. Thank you.
Bye.